Spine Academy is a pre-surgical education presentation provided by Alaska Regional Hospital's Certified Spine Program. We will be reviewing information on preparing for surgery, home preparation, and what to expect while you are here at the facility. This educational information does not replace instructions provided by your surgeon or their staff. If discrepancies are noted, always follow your surgeon's specific instructions. It is important to understand how your neck and back function. We will be discussing some of the following topics. We will be discussing risk factors for back pain, spine anatomy, types of spine surgery, risks of surgery, and pain management. To do this, we will focus on the skeletal, muscular, and nervous systems as they relate to your spine. There are some factors that can predispose patients to some back disorders. One is age. We do find that back pain is more common in patients starting around age 30 or 40. Lack of exercise, the weak, unused muscles in the back and abdomen can cause back pain. Excess body weight puts extra stress on the back. And improper lifting by using the back instead of the legs can lead to back pain. There are some diseases like arthritis, osteoporosis, and cancer that also can contribute to back pain. We also find that people who are prone to depression and anxiety appear to have a greater risk of back pain. We believe this is because stress can cause muscle tension, which can contribute to back pain. Smokers also have an increased risk of back pain. This may occur because smoking can cause coughing, which when excessive can cause herniated discs. Smoking also decreases the blood flow to the spine and increases the risk of osteoporosis. The spinal column is made up of 24 vertebrae. The vertebrae are the bones of the back. Each vertebrae has a hole in the center, so when stacked on top of each other, they form a hollow tube that holds and protects the spinal cord. These are the building blocks of the spinal column. The cervical spine is made up of the first 7 vertebrae. It is much more mobile than other sections of the spine. Think about the directions and angles you can turn your head and neck. Although it is very flexible, it is at risk for injury from strong, sudden movements due to limited muscle support. The cervical spine supports the weight of the head, which is a lot of weight for these small, thin set of bones. Next is the thoracic spine, made up of the middle 12 vertebrae that run from the base of the neck to the abdomen. It is the only region of the spine that connects to the rib cage. This area of the spine is built more for stability than mobility, like the cervical and lumbar spine. The lumbar spine is the region of the lower back and consists of 5 vertebrae. These vertebrae are the largest of the vertebrae and they connect to the pelvis. This is where most of your weight bearing and body movement takes place. This is where people also tend to put a lot of pressure from lifting, twisting, and carrying heavy objects. The sacrum and coccyx are made up of bones that fuse together as we develop. The sacrum is the platform when we are sitting, and it can also be an area that can cause lower back pain. The coccyx, which is also known as the tailbone, does help support the body and connects some important muscles and ligaments. The spine segments form 3 natural curves that are important for balance and the ability to stand upright. Flexibility in the back and leg muscles are important for good, proper function of the spine. The abdominal and back muscles must be balanced for good posture. There are many types of spine surgery, but most involve reducing the pressure on the spinal cord or the nerve roots that have not responded to other treatment. Nerves transmit electrical signals to the brain for sensation and muscle movement. Nerves work with specific muscle groups. Spinal nerves are the major nerves of the body. Each contains sensory fibers that relay sensation and motor nerve fibers that relay signals between the spinal cord and parts of the body. There are 31 pairs of spinal nerves that come from different segments of the spine to specific areas of the body. This picture, called a dermatome, shows the region of the body that relies on specific nerves. Think of the spinal cord like a freeway that handles a large amount of traffic or nerve signals that are traveling between the body and the brain. The spinal nerves are like the on and off ramps of the spinal cord. If there is an area of the body where there is lack of sensation or muscle control, there is a problem with that connected spinal nerve. So there is no or limited traffic going to or from that area. The anterior portion of the vertebrae is called the vertebral body. The posterior portion is formed of 4 parts that make up the vertebral arch. The vertebral bodies are anchored together by an intervertebral disc. These discs provide padding and allow for movement between the vertebrae. The disc has a tough fibrous outside and a softer gel-like inside that contains a high water content that resists compression. With age, the water content declines, causing the disc to become thinner, which decreases total body height and reduces flexibility and range of motion that can cause bending and movement to be more difficult. If the outer portion becomes weakened, some of the inner substance can protrude, resulting in what is called a ruptured or slipped disc. This can cause compression of a spinal nerve. Your surgeon will determine and discuss the most appropriate surgery for you. We're going to talk about some surgical variations. A decompression is performed to relieve pressure on the spinal cord or spinal nerve roots. A discectomy removes all or part of a spinal disc. A laminectomy removes the bony area that makes up the back part of the vertebrae. A foraminotomy widens the opening where the nerve root leaves the spinal canal. A fusion is performed by placing bone graft or bone-like material within the space between the vertebrae. Metal plates, cages, screws, and rods may be used to hold the vertebrae together so they can heal and fuse. A disc arthroplasty is replacing an existing disc to restore spacing while preserving motion. There are different approaches to perform spinal surgery. In cervical or neck surgery, it can be approached anteriorly, which is from the front of the neck, or posteriorly, which is from the back of the neck. For lumbar surgical procedures, it can be approached anteriorly, which goes through the abdomen, posteriorly, which goes through the back, or laterally, which is approached from the side. As with any type of surgical procedure, there are certain risks associated with spine surgery that your surgeon will discuss. Though complications are rare and extensive measures are taken to minimize these risks, it is important that you are aware of these possibilities and some actions that can be done to minimize these risks. Spine surgery carries the risk of neurological injury. Although rare, it can include serious sensory and motor injuries. Due to this risk, intraoperative neurophysical monitoring is used. This allows the surgeon to assess spinal cord function through real-time feedback from individual nerve roots and motor and sensory tracts. The goal is to alert the surgeon to prevent damage and preserve the functionality of the nervous system. You will meet the neuromonitoring specialist who will explain this further while in the preoperative area. Spinal fluid leak occurs when the fluid surrounding the spinal cord leaks. Most common symptoms is a headache that occurs or is made worse by sitting and standing. If a spinal fluid leak was evident during surgery, you will be requested to remain on bed rest without elevating your head. These normally will resolve but could require additional surgery. Infection prevention begins before surgery, and nutrition plays a vital role in healing. Protein is the building block of tissue. Some good sources of protein include lean meats, poultry, fish, eggs, dairy products, beans and legumes, and nuts and seeds. It is important to increase those lean protein sources before surgery and during your recovery. Protein supplements can be beneficial after surgery if there is a loss of appetite. Vitamins A, C, and E are antioxidants that play a key role in immune function. Vitamin C can be found in citrus fruits, strawberries, kiwi, broccoli, and bell peppers. Good sources of vitamin A are liver, sweet potatoes, carrots, spinach, and kale, and vitamin E can be obtained from spinach, nuts and seeds, and fortified cereals and vegetable oil. Vitamin D helps the body absorb calcium and helps to reduce inflammation and boosts the body's natural immune response. Our bodies produce vitamin D from the ultraviolet rays of the sun, so get out and enjoy a nice sunny day. Many people, especially Alaskans, don't get enough vitamin D from the sun. Foods rich in vitamin D include fatty fish like salmon, beef liver, egg yolks, milk, and some breakfast cereals that are fortified with vitamin D, along with cheese, yogurt, and dark chocolate. Omega-3 rich foods help reduce inflammation and promote healing. They can be found in fatty fish, walnuts, chia seeds, and flax seeds. Ensure you are consuming enough calories as your body's energy needs increase during the recovery phase. Concentrate on whole foods that are minimally processed. Nicotine, including smoking, vaping, and smokeless tobacco products, can interfere with anesthesia and decrease blood supply to areas of healing. Stop all nicotine products prior to surgery as early as possible. Even a few days before surgery can be beneficial. High blood sugar levels can increase your risk of infection and delay healing. Stress can also increase blood sugar levels. We may be checking your blood sugar levels throughout the surgical process. Low body temperature can also have an effect on infection potential. You will be provided a forced air warming blanket in the preoperative area and a warm blanket for transfer to the operating room, which is normally very cold. The goal is to maintain your body temperature and prevent hypothermia. Nasal screening for Staphylococcus aureus is required for all spine patients prior to surgery. A positive test does not mean you have an infection or that you can't have surgery, but it does mean you are at a higher risk for infection. The antibiotics given before surgery depend on the results of this test. MRSA, or methicillin-resistant Staph aureus, does require an additional antibiotic. Your surgeon may also prescribe an ointment called mupirocin to place inside the nostrils twice a day for 5 days prior to surgery for that positive MRSA test result. For all patients that are having spine surgery, we provide a product that is an alcohol citrus solution to treat the nostrils while in the preoperative area. Your preoperative nurse will explain this process and provide you with that product. Patients are requested to shower the evening prior and morning of surgery with an antimicrobial soap. Soap may be provided by your surgeon, or it may be obtained during pre-admission testing here at the hospital, or by coming by the hospital and requesting soap from the registration desk staff. If you are unable to obtain this soap, you may use over-the-counter antibacterial soap like Gold Dial. We will discuss this showering process later in the presentation. Sterilization of surgical instruments and minimizing staff in the operating suite are also important to infection prevention and are a priority of ours. Excess bleeding during surgery can be minimized by discontinuing anticoagulant medications and over-the-counter medications like aspirin, ibuprofen, and many herbal supplements. Medications like Ozempic, Mounjaro, and Jardiance need to be discontinued also. Most of these medications and others need to be stopped anywhere from 3 days to 2 weeks prior to surgery. Be sure to discuss all medications with your surgeon. Blood clots after surgery may occur up to several weeks after surgery. Blood clot prevention can be maximized substantially with early and frequent ambulation, movement, and foot pump exercises. While in the hospital, you will be provided with a sequential compression device for use here in the hospital. These are special leg or foot wraps connected to a machine that inflates and deflates the wrap. The pumping action acts like your muscles to help with blood flow and prevent blood clots. You will also be wearing compression hose or TED hose that you will be required to wear for a few weeks after surgery. You may remove these stockings daily for about an hour or so to allow the airing out of your legs and also to look to see if there are any irritations caused by the stockings. It is important that you elevate your legs for about 15 minutes prior to reapplying the stockings. After discharge, walking every 30 to 60 minutes and performing the foot pump exercises will be important to prevent blood clots. Dysphagia, or difficulty swallowing, is most common in the early postoperative period after anterior cervical spine surgery. Most patients will recover their ability to swallow within a few days after surgery, but it may linger longer. You will be started on clear liquids, then progressed to softer foods. Speech therapy will evaluate and assist you with techniques and dietary modifications as needed. Dysphagia is more prevalent in females, smokers, and overweight patients. Injury to the kidneys, ureter, or vascular is when surgery is performed by an anterior approach. The approach is performed by a vascular surgeon who also performs the surgical closure after the spine surgeon completes his part. You will be requested to attend a consultation with the vascular surgeon prior to surgery for a full explanation of the procedure and additional risks. Failure to fuse or pseudoarthrosis is when there is a failure to achieve bony fusion or the locking of the bones together. Some of the causes include tobacco or vaping products. These products can decrease bone mineral density. They can reduce bone formation, which then can delay healing. Some NSAID products can also delay healing. Many surgeons will request not consuming NSAID medications for a period of time after surgery. Another potential cause of failure to fuse is the loosening or breakage of implants that are put in to allow bony healing. This could be caused by a fall or not following activity instructions. Other factors include infection and being overweight that can also contribute to failure to fuse. Need for additional surgery can result from bleeding, infection, failure to fuse, among other things. Be diligent in preparing for surgery and following your postoperative instructions, especially those regarding precautions and your activity. Adjacent segment disease is a condition where the level above or below the fused area degenerate. This is due to these levels making up for the lack of movement in the fused area. This can result in needing additional surgery. The most common complication to anesthesia is nausea and vomiting, but it can include other things like sore throat, dry mouth, shaking and chills, difficulty urinating, or confusion. Most people have no issues or only minor issues after surgery, but there is a possibility for a severe reaction. Make sure to discuss prior history and family history, especially with issues from anesthesia, with your anesthesia provider. Anti-nausea medications can be given prior to surgery to prevent post-op nausea and vomiting. Aromatherapy can also be very beneficial as a treatment or a complementary treatment in addition to other medical treatments. Let's talk about some other things that you will need to do to prepare for surgery. Registration is one of the tasks that need to be completed prior to surgery. This can be done by calling 907-264-1952, and it can also be done online at alaskaregionalhospital.com. You will need to have pre-surgical lab work and x-rays that your surgeon will order. You will need to have that MRSA testing. This testing can be performed by your primary care physician, or it can be done here at the hospital. We do prefer this testing be done at least 1 day and up to 30 days prior to surgery. You will receive a pre-admission phone call, or if you are doing pre-admission testing here at the hospital, it will be done at the same time. The pre-admission testing nurses will be filling out a medical questionnaire. Please have a list of your medications available for this phone call or visit. You may also be required specific clearances by cardiology, urology, pulmonology, or any other specialists that need to verify that you are safe to proceed with this surgery. The night before surgery, make sure that you are eating a healthy dinner high in protein, and please refrain from any alcoholic beverages. Again, after midnight, nothing to eat. After midnight, nothing to drink at all. that morning, unless your surgeon has told you otherwise if your surgery is scheduled for later in the day. Make sure you are following the guidelines for medication that you have discussed with your doctor or through our pre-admission testing nursing staff. If you are a diabetic, it is important to discuss your diabetic medications and how to take those or refrain from taking those the morning of surgery. Let's talk about infection prevention and pre-surgical showering. Please do not shave any parts of your body for 24 hours prior to surgery. The night before surgery, I'd like you to get into the shower, do your normal body wash and shampoo with your normal products that you use. Then I would like you to take the applicator provided by your surgeon or a clean, freshly laundered washcloth with half a bottle of the chlorhexidine soap provided by the hospital. Once you have the washcloth wet, I would like you to turn off the water and apply that liquid soap from your chin all the way down to your toes. Again, this can be done with a washcloth or whatever your surgeon has provided for you. Please do not get that soap into your eyes or your ears. I do want you to leave that soap on your skin for at least 2 minutes. That is why we asked you to turn the water off. Once 2 minutes has passed, you can turn the water back on, rinse off well. When you do get out of the shower, I want you to dry your skin with a freshly washed towel. And I would like you to get into clean bedclothes and sleep in freshly laundered sheets. The morning of your surgery, we would ask that you take another shower. It is not necessary to shower with your normal soap and shampoo. We would like you to perform the shower as described on the previous slide from the night before with that same chlorhexidine soap. Remember, after applying the soap, leave it on your skin for about 2 minutes prior to rinsing. After coming out of the shower, we would like you to put on clean clothes that you can wear to the hospital. Remember to wear something that is loose-fitting and easy to put on and off. Some of the worst things to wear are blue jeans or yoga pants. The morning of surgery, after your shower, please do not place any lotions, perfumes, powders, or deodorant on your skin that morning. It is now the day of surgery. On the day of surgery, we would like you to leave several items at home. The first one is large amounts of money, any personal valuables, especially jewelry. It is important that all jewelry is removed prior to coming to the hospital. We would like you to leave all medications at home. Our pharmacy is well equipped with medications for your stay here at the hospital. The only exception is you can bring your inhaler into the preoperative area. Also, please leave any negative thoughts or attitudes at home. Negativism after surgery usually results in patients not following post-operative instructions, hence not doing well after surgery. There are some things we would like you to bring to the hospital. The first one is a list of all your medications, including dose and frequency and the time you take it, and also any allergies that you are aware of. You do want to bring some form of identification and your insurance card. If you use a CPAP or BiPAP unit at home, please bring this unit with you to the hospital. We will provide the fluid for your unit. You can bring personal hygiene items like deodorant, shampoo, toothbrush, and toothpaste. We do offer patients a toothbrush and toothpaste while you are here at the hospital, but if you do prefer to bring your own, feel free to do so. Bringing a mobile device like your phone or an iPad can help with diversion after surgery. Sometimes people like to play relaxing music. Sometimes people do bring a book or a magazine that will help them again to divert their attention away from sitting in the bed and feeling like you are uncomfortable. At the hospital, we do have DirecTV. We also do have internet access, but remember that our internet access is unsecured. So please do not be checking your bank accounts or purchasing items online while here at the hospital. We would like all lumbar spine patients to have a two-wheel walker available for the day of discharge. While here at the hospital, we have walkers in each room for patient use, but it is important that you do have a walker, if you need one at discharge, in your vehicle to allow you to get from your vehicle into your home. Make sure you are wearing comfortable clothes. Again, something loose-fitting, preferably something with a very wide neck if you are having cervical spine surgery because you may be wearing a cervical brace. It is important to also have good, solid-fitting shoes that have a rubber sole. We prefer that you do not bring slippers or wear loose-fitting slippers or shoes at home during recovery. It is also important to bring a pair of shorts or a pair of lounging pants that you can wear while you are here at the hospital, so while you are walking the halls, we can maintain your modesty, especially if you're wearing one of our hospital gowns on top. It is important to bring glasses, hearing aids, and dentures. If you use them at home, you will need them here at the hospital. But most importantly, it is very important to remember to bring that confidence in yourself. On the day of surgery, you will be instructed to arrive at the hospital approximately 2 hours before your surgery scheduled time. Your surgeon will build this into the time that he is telling you to arrive. If he tells you to arrive at 5:30 in the morning, that means your surgery is scheduled around 7:30. At that 5:30 time frame, the only doors to the hospital that are opened is the entry at the emergency room. After 6 o'clock a.m., all of the doors are open for entry into the hospital. You will check in at the registration desk on the second floor. You will then be instructed to go to the OR waiting area and also to check in with that receptionist. A nurse from the pre-surgical room will come and get you to help prepare you for surgery. They will start an IV, get you into a hospital gown. They will make sure all of your consent forms are signed, in addition to providing you with a forced air warming blanket to prepare you for the cold operating room. While you are in the pre-surgical room, ask about the texting system available for families and obtain the patient-specific access code so your family can receive text messaging on the updates throughout your surgical process. You will be visited by your surgeon, the anesthesiologist, and the operating room nurse while in that pre-surgical area. At that point, your family and friends will be asked to leave while we are taking you to the operating room for your procedure. After surgery, you will be taken to the recovery room, sometimes referred to as the PACU or post-anesthesia care unit. Your surgeon will call your family or whoever you have designated for him to call after surgery. This is a good time to note the time because normally about an hour after this phone call will be the same time that you will be going either into stage 2 recovery or be admitted to the hospital unit. Now let's talk about after surgery. Once the anesthetic begins to wear off, you will be moved to stage 2 recovery if you are an outpatient or to your hospital room on the orthopedic and spine unit if you are remaining as an observation or inpatient. All of the rooms are private rooms with private baths. Alaska Regional Hospital is a Joint Commission certified spine center. This certification is proof of our commitment to providing an exceptional level of care by maintaining and upholding the highest standards and clinical practice guidelines. There are many members of your spine care team. One of those members is the charge nurse or nurse leader on the unit that you will be staying on. You will also have a bedside nurse who will be assigned to your care. Registered nurses in the facility all wear navy blue scrubs. We also incorporate nursing assistants who are an integral part of our patient care team. Nursing assistants take vital signs and help ambulate patients in addition to multiple other duties. You will also be meeting with a physical therapist and occupational therapist, both whose goal is to prepare you for your recovery at home. Your surgeon is an integral part of your care team, but your surgeon may not be the expert at some other medical issues. There are times when your surgeon will request one of our hospitalists, who is a primary care physician, to also assist with your care. When you arrive in your hospital room, you may have all or any of the following equipment. Oxygen is being provided through a flexible tubing with small prongs that go into your nose. You may have a pulse oximeter, which is measuring the oxygen concentration in your blood. Our goal is to have your oxygen concentration at least 93% while awake and while sleeping. You will have IV fluids and potentially IV medications. We will discontinue IV fluids once you are taking fluids and food by mouth, but the IV itself will remain in place until discharge. It is the last thing we remove just in case we need to give you additional fluid and medications. You will be wearing the anti-clotting devices, or those sequential compression devices. You will also have on compression stockings. These stockings will be worn after discharge. We will provide you with an additional pair so that they may be alternated while you are at home while you are washing one pair. You potentially will have a drain. Sometimes this drain tube is one of the things that determines when you can be discharged. We prefer to not discharge patients with drains, but sometimes that is a necessity. You will have a dressing over your incision. This dressing is normally a waterproof dressing that can be worn while in the shower. If you do need to do dressing changes at home, we will not only provide you with the instructions, but we will provide you with the dressing supplies that you will need. You may come to the unit with a Foley catheter. This catheter is inserted in the operating room after you are asleep, and we prefer to remove this catheter as soon as possible after surgery. One of the criteria to have that catheter removed is you have to be able to ambulate at least to the bathroom and back. You also will be using an incentive spirometer, which is a device that helps prevent pneumonia. This incentive spirometer should be used about 10 times an hour for those first several days. Your nursing staff will instruct you on the use of the incentive spirometer. Understanding pain is an important part of pain management. There are many causes of pain. It is a natural response to illnesses, surgery, and certain procedures. There are two types of pain. One type is acute pain. It usually comes on fairly suddenly and passes quickly. This is surgical incision pain. The other type of pain is chronic pain, and this can persist over weeks, months, or even years. It is often the result of any injury, illness, or disease. Our goal is to reduce your pain and make it manageable so you can work with physical therapy and occupational therapy and become as independent as possible during your hospital stay. Please note, you will experience a different kind of pain. You'll experience that acute incisional pain, which may be different than the pain that you had prior to your surgical procedure. Pain after surgery can be managed successfully with your patient care team and you. Remember, you will not be totally pain-free after surgery. We are committed to treating and managing each patient's pain after surgery. We use a Wong-Baker FACES pain rating scale. This pain assessment tool utilizes a scale of 0 to 10 with corresponding facial expressions. 0 means you have no pain. 10 means it's the worst pain. It is important to add a descriptor when communicating your pain. We need to know if it is a throbbing pain, dull burning pain, stabbing pain, or a muscle tightness pain. Each of these pains may need a different kind of medication to help control. There are different routes in which we give pain medications to treat your pain. One of those routes is IV or intravenous. The effects from IV pain medication are observed fairly quickly, but they are also short-acting. Oral pain medication or pain medication taken by mouth can take 20 to 30 minutes or longer for the effects to be noticed. Oral pain medication does last a lot longer than IV pain medication, and we need to make sure that your pain is managed by oral pain medication prior to your discharge. Now, the real question is, when can I go home? Your care team determines when you can go home, and some of the factors that go into that decision include, can you get in and out of bed by yourself or with very limited assistance if you have limited assistance at home? Are you independently completing daily activities? Can you eat without nausea and vomiting? Can you urinate once that catheter has been removed? Are you taking oral pain medications that are controlling your pain? Have you been able to pass gas, or have you had a bowel movement? After surgery, it is important to note that the intestines are moving as they were prior to surgery. That is the reason why we ask if you have been passing gas. It is important to know this prior to giving you a lot of solid foods. When it comes to the bowel movement, you may or may not have a bowel movement while you are here at the hospital if you're only here for a short period of time. But it is important to maintain a good bowel regime. After surgery, your surgeon may suggest that you get a stool softener or a stool softener with laxatives to verify that you have good bowel movements after surgery. The combination of anesthesia, decrease in your mobility, decrease in your fluid intake, and the addition of narcotic pain medications can all contribute to constipation. Have you been cleared by physical therapy and occupational therapy? We want to make sure that you are safe to go home to whatever environment you are being discharged to. The day of discharge. Prior to leaving the hospital, there are a few tasks that must be completed. If you need medical equipment, we need to verify that that equipment is available. We prefer that you obtain medical equipment prior to surgery if possible, and that would include a walker for lumbar spine patients. Has your surgeon completed your discharge orders? He will enter them into our electronic health record, and if he does provide you with additional medications, we will reconcile those medications with all medications that you have taken prior to surgery. Your nursing team will then verify your discharge orders and prepare written instructions. We will then assist you in preparing to leave. We can help you to shower if you are approved to shower, and then of course helping you to get dressed, which sometimes is done by occupational therapy, who can teach you some helpful hints on best ways to get dressed and still abide by your precautions. Your nurse will then review your discharge orders once your family member or whoever is coming to pick you up. These discharge orders will include your medications, what appointments and therapy that you have, and other responsibilities that you need to verify after discharge. Once these are complete, we will take you to the entrance of the hospital where your family is parked, and we will assist you to your vehicle. We will take you to the hospital entrance by wheelchair. Some important things to remember when you get home. When it comes to effective pain management, the tips that you've learned here in the hospital will also work at home. To get the best pain relief possible, remember these points. Use your medication only as directed. Do not take it prior to the time that your next scheduled medication should be used. Make sure that as pain lessens, that you try decreasing your pain medication, either by decreasing the dose or by extending the time between doses. Remember that oral pain medication takes time to work. Normally 20 to 30 minutes is how long it may take to see the effects of that pain medication. Remember to time your medication so that you can take it before activities, especially things like physical therapy or maybe taking a walk. You can use cold packs or ice packs to assist in pain control and swelling. Please remember, do not place these directly on the skin. You definitely want a thin barrier between the ice pack and your skin. Limit using those cold packs to about 20 to 30 minutes every couple of hours. Make sure that if you are prescribed multimodal pain medication like Tylenol or gabapentin, that you continue to use that medication, which can help to decrease the use of narcotic pain medications. Make sure that you are maintaining your precautions and good posture. Remember that your hips and your shoulders should always be kept in alignment when you are moving after surgery. Remember infection prevention when you get home. We want you to have the best experience when it comes to your healing. Therefore, it's important that you follow some of the guidelines that we will talk about to prevent infections. Make sure that you are keeping your wound clean and dry. Remember, shower only. Do not soak your incision line. And also, if you are using cold packs, make sure that the barrier between the cold pack and your skin does not remain wet on your skin. When you get out of the shower, make sure you pat dry. And if you are instructed to keep the incision line covered, make sure that you are doing that. You will need to follow your dressing instructions, and remember that dressing supplies will be provided as you need those. When you do get those supplies at home, make sure that you keep them in a clean, enclosed container, and make sure that you are changing your dressings in a clean environment. It is important to wash your hands with soap and water. Wash your hands before removing your dressing. Wash your hands after removing the dressing before applying the new dressing, and then wash your hands again when you are finished. Remember, do not apply any lotions, creams, ointments, or anything at all to your incision line unless your surgeon specifically instructed you to do so. Watch for signs and symptoms of infection. These include redness, pain, heat, or swelling at the surgical site that is progressively getting worse. If you have a new drainage, change in the way the drainage looks or smells may be indicative of an infection. Make sure you are calling your surgeon. If you have a rise in the temperature over 100.5 to 101, you should be calling your surgeon. If there is a change in overall how you feel, nausea, vomiting, dizziness, trouble breathing, being excessively tired, or fever and chills, again, may be something that you want to touch base with your surgeon regarding. You want to watch for signs and symptoms of blood clots. DVT, or deep vein thrombosis, is a blood clot that normally happens in the leg, and it's primarily in the calf area. This is a new pain that doesn't go away. Also, swelling that doesn't go away with elevation could be indicative of a deep vein thrombosis. Call your surgeon if you have any of these symptoms. It is also important that you are watching for signs and symptoms of a pulmonary embolism, or PE, which is a blood clot that goes to the lungs. Things like shortness of breath, chest pain, or difficulty breathing can be indicative of a pulmonary embolism. If you have these symptoms, go directly to an emergency room. You may need to keep some records at home. Some of those include pain medication. Pain medication does cause you to be forgetful, so jotting down the time that you took the pain medication can be helpful so that you can take this pain medication as needed and again decrease the medication as your recovery progresses. You may want to jot down your walks. Remember to start with short distances every hour or so. Make sure you're standing upright and increase the time and distance of your walks as you tolerate them. You may want to jot down some exercises and how many you've done. In the physical therapy pamphlet, it does discuss exercises like ankle pumps, leg exercises, and avoiding repetitive bending. Again, remember to keep track of your bowel movement. Prevention is important. High fiber foods, plenty of fluids, and stool softeners can be very beneficial in maintaining good bowel habits. You may want to take a picture of your surgical site once the dressing is removed, especially with those hard to visualize areas. This can be helpful in using it as a comparison if concerns do arise about your incision site. Nutrition is a vital part of overall healing after surgery. Eat several servings of fruits and vegetables, drink plenty of fluids, and remember, protein, protein, protein is essential for healing after surgery. Increasing your activity and exercises will enhance the recovery process and also aid in constipation. Continue your prescribed precautions and increase activity as tolerated. Maintain neutral alignment of your spine during activity. Alternate sitting, standing, walking, and lying on your back throughout the day. Don't get discouraged. Plan and ask for assistance. Make sure that you are getting uninterrupted sleep and frequently alternate rest with activity.
Hello, I'm Gary, an occupational therapist here at Alaska Regional Hospital. And right now we're going to be talking about therapy that you are going to be receiving in the hospital, as well as preparations you can do before surgery to prepare for after surgery. I do want to let everybody know that therapy in the hospital will be individualized to the patient and their specific discharge plan. Some patients have higher needs and will require more therapy. Some patients have less needs and require less therapy. It is important to note that the things that we are going to be talking about may not be necessarily mandatory for everybody, but they're going to be good suggestions and a good generalized overview of things to prepare for therapy in the hospital and for going home. When it comes to therapy in the hospital, there's going to be three major goals that all the therapy can kind of be boiled down to. And those goals are going to be centered around a safe discharge home. The first major role that we're going to have is going to be no falls. We want to practice safe mobility and safe activity to make sure that we focus heavily on fall prevention. The second big goal is going to be no infections. We want to make sure that your home environment is safe and set up properly to avoid infections post-operatively. And lastly, we don't want you breaking the movement restrictions. We refer to these as precautions after surgery to make sure that we can protect your surgical site. So let's highlight that last goal of therapy, spinal precautions. You're going to be hearing a lot about these spinal precautions and a lot of repetition with it because they are so important. So let's get into those. So now let's talk about those restrictions I just mentioned. You're going to hear the term spinal precautions mentioned often throughout your stay at Alaska Regional Hospital. We want to remind you that those spinal precautions are movement restrictions, and you can use those terms interchangeably. When it comes to your movement restrictions, these restrictions or precautions typically last for 6 to 12 weeks after surgery, and then we slowly progress back to normal activity and normal movements. For both cervical and lumbar patients, we use the acronym BLT to describe these precautions. But instead of the BLT sandwich, like the bacon, lettuce, tomato, we actually want you to do no bending, no lifting, no twisting for those 6 to 12 weeks. Sometimes we get a little creative and we say BLT on rye or BLT with ranch, and that R stands for reaching. When it comes to bending, we do not want you bending to cause any strain to your spine. For cervical neck patients, that's going to be bending heavily at the neck, and for low back patients, that's going to be bending at the waist. When it comes to lifting, those restrictions are going to be for about 10 pounds. Normally they're described as the weight of a gallon of milk because a gallon of milk weighs approximately 7 or 8 pounds. So for 6 to 12 weeks, we do not want you lifting anything heavy. Please also note that when it comes to ergonomics, the further you hold something out from your body, the heavier it feels. So even if you're getting close to that 10-pound weight restriction, we want you holding things close to your body to eliminate some leverage. When it comes to twisting, for cervical patients, that's going to be turning your head side to side. And for our lumbar patients, that's going to be twisting at the waist to do something like reach behind you. And lastly, reaching. We don't want you reaching out for things because it can put you in a compromising position to break the other BLT rules or to put you at risk of a fall. In this slide, I wanted to include some pictures to kind of explain the precautions a little bit better because sometimes just the sound of my voice doesn't drive the point home. On the left side, the left column, you can see the thoracic and lumbar patient precautions. So the top one is going to be no bending. We also want to note that bending can happen if you're sitting down. If you're sitting in a chair, bending forward as if to put on your shoes or put on pants can also count as bending, and we want to eliminate that. That means that for all of our spine patients, whether it's lumbar, mid-back, or upper back cervical patients, getting lower body dressing completed will be difficult. So things like pants, underwear, socks, and shoes will be a little bit tricky, and we'll talk about that a little bit later. As we go down, though, you can see a picture of no lifting. And again, I already mentioned roughly 10 pounds is going to be your lifting restriction. So think anything heavier than a gallon of milk, we do not want you picking up. And lastly, at the bottom, no twisting. Now, when it comes to cervical patients, we are going to be focused more on your neck in those precautions of no bending, no lifting, and no twisting, especially in that cervical region. However, please note that your entire spine is a system. And if you do a lot of bending or twisting in your low back, you may feel it in your neck. And if you do a lot of drastic movements with your neck, you may feel it in your low back. So generally, we do encourage all of our spine patients, no matter where your surgery is, to move very robotically, to follow those precautions all across your spine. So now that we've talked about those precautions, let's talk a little bit about therapy that you're going to be receiving here in the hospital. Again, please remember it's going to be individual to the patient and their discharge plan. Whether you get a little therapy or a lot of therapy is all going to depend on you and your needs. So one of the first therapists that you're going to get a visit from is going to be physical therapy. Now, most people are relatively familiar with physical therapy, but here in the hospital, they're going to be focusing on mobility and exercises. So things such as going up and down the stairs, walking, getting in and out of bed, making sure that you're moving safely, and again, focusing on fall prevention and safe mobility going home. Things that physical therapy really focus on are going to be walker usage and gait belt usage. So here are some pictures of those items that physical therapy may be teaching you how to use. On the left is a picture of a front-wheeled walker. This is the most common type of walker we prefer our spine patients to use while here in the hospital, and we do encourage you to get your own walker prior to surgery. While you're in the hospital, you will be using one of our walkers in your room and on the unit. However, going home, you cannot take our walker with you. That is why we try to encourage patients to get one prior to surgery. You can get these walkers locally from a big box store or pharmacy, as well as from a lending closet, or even buying them secondhand if they are in good working order. On the right is a picture of a gait belt. It's an object that we use. It's basically a cloth belt that we put around you in case you need help walking, and we can help stabilize you. It will be yours to take home after surgery, as we do not reuse these gait belts. Another activity that physical therapy may teach you about is getting in and out of bed. To do this, they use a technique known as the log roll. The log roll is a simple way to get in and out of bed while eliminating a lot of pain and keeping you within those precautions or movement restrictions that you have. To do the log roll, you can see with the image on the left, you start out by bending your knees, rolling to your side, and then once you're on the edge of the bed, you slowly bring your feet over the edge and push up with your hands into the sitting position. To get back into bed, it's the same technique, just in reverse order, where you sit down, lay to your side, then roll to your back, slow and in control. This is something we do encourage people to try prior to surgery, as getting in and out of the bed is sometimes one of the trickiest things to do after surgery. Now, some patients do have a hard time getting in and out without something sturdy to grab onto, and on the right is an image of a temporary bed rail that you may be able to acquire locally from a big box store or pharmacy, or even online. And these normally slide underneath the mattress and give you a rail to hold on to get in and out of bed. So the next therapy that will be visiting you while you're in the hospital is occupational therapy. Though it's not as well known as physical therapy, it's common for all of our patients to get occupational therapy here in the hospital. Occupational therapists work on activities of daily living, most commonly known as bathing, dressing, grooming. All those self-care items that you want to do at home and do as independently as possible is what we're going to be focusing on after surgery. We're going to be using various equipment such as reachers, sock aids, toilet aids, long-handled sponges. Certain devices will help you compensate because after surgery you're going to have those movement restrictions. And getting things like pants on and underwear on or socks on are going to be very tricky after surgery if you're not allowed to bend, lift, or twist. So one of the common items that you'll be receiving after surgery is a reacher, or some people refer to them as grabbers. On the left picture, you can see just a standard reacher. In the middle picture, you can see somebody using that reacher to help them get a blanket while they're on the couch. And the reacher is a great item to have around the house because it can really help you with those day-to-day things to avoid bending down or reaching too far for certain items. On the right, though, is a diagram of how to get your pants on and off using a reacher or something known as a dressing stick. Again, after surgery, you're going to have rolls on bending, so getting your pants on may be a little bit tricky. After surgery, occupational therapy will go over how to use a reacher and how to get your pants on using that technique on the right. Another common device that occupational therapy uses is called a sock aid. On the left, you can see a common model of sock aid, and it's basically a plastic tube with a rope. The middle, though, you can see a stock image of a person using it to get their sock on. You grab the frame, you put your sock on it, you throw it out, and you reel it in just like you're going fishing for your foot, and you pull that sock up. And again, there's another diagram on the right to show the technique using a softer sock aid where you slide the sock on again, While you're sitting down without bending, you toss out that sock aid and you reel it in towards your foot to help you get those socks on after surgery safely and again, hopefully without too much pain. Another activity that occupational therapy will be reviewing with you is going to the bathroom. It's a topic that many people do not want to discuss. However, it is very important because one of the things that people break precautions with is wiping after going to the bathroom. So we may be providing you with a toilet aid, and that can be an object on the left, such as a bottom buddy, or one in the middle, known as a toilet tong. These items allow you to grab onto toilet paper and extend your reach so you can reach behind you without twisting. The option on the right, the long-handled sponge, is used for bathing, and it allows you to reach your legs or lower extremities without bending or reaching too far after surgery. And the last therapy that you may receive in the hospital is speech therapy. Now, normally, speech therapy is ordered for our cervical patients only. So after neck surgery, we want to make sure that our neck patients are able to talk and swallow without much discomfort and to be able to safely eat foods. However, if you have low back surgery and you have some discomfort in your throat, we may be able to order speech therapy for you to also come and do an assessment on you as well. After surgery, you may notice that your physician ordered a brace for you. Your physician will determine if you need a brace after spine surgery. It is designed to help stabilize and protect your spine while healing. If your surgeon does decide that you need a brace, they will be determining the type of brace that you require. Your surgeon will also be determining if you need to continue wearing your brace and for how long you need to wear it. If before surgery you were either given or fitted for a brace, please bring that brace in with you during surgery because we will be test fitting it and practicing getting it on and off with therapy after surgery. If you are given instructions on your brace, please follow those instructions for application, use, and duration. The common types of braces are going to be cervical collars, and the brands that we use are Aspen Vista and sometimes what's called the Miami J. And other braces for low back are going to be the lumbar sacral orthotic or thoracic lumbar sacral orthotic, and the acronyms for those are LSO or TLSO. So here are some pictures of those braces I just mentioned. On the left, we have the Aspen Vista collar. This collar is for our cervical spine patients, and most of our cervical spine patients do get an Aspen Vista after surgery. Some of our neck patients also get a soft collar, and it depends on your surgeon's preference and the type of surgery that you had. For our low back patients, sometimes we do see the LSO or the TLSO. These are not as common as the cervical collars, but they do occur. The picture in the middle is the LSO, lumbar sacral orthotic, and this is known as an off-the-shelf or a prefab option because it doesn't necessarily require custom fitting and it is an adjustable brace. The brace on the right is the TLSO. Sometimes we refer to this as the clamshell, and this is a custom build and you need to be fitted with this prior to surgery. This is not something that you can get off the shelf, and it's something that'll have special orders from your physician for after surgery with this item. So now let's talk about preparing and planning your home for safe discharge home after surgery. We're going to be going over home safety, fall and infection prevention. Because again, remember my 3 big rules: no falls, no infections, and don't break those precautions whenever you get home after surgery. So we have some common suggestions that we give most patients to prepare for surgery. The first is going to be cleaning your home and vacuuming your carpets. The second, laundering your bedding and all the comfortable clothes you're going to be wearing over the next few weeks. Disinfecting and cleaning your bathrooms, including your toilets, showers, and sinks. Removing all clutter. And this has a lot to do with fall prevention, as tripping over small cluttered items is a big danger going home. And lastly, prioritizing the easy access to common use items. Think about things that you're going to be using over the next 6 to 12 weeks. Again, that's the length of time of your precautions. And my catchphrase is waist to face, because that's where you want to put items that you're going to be using over the next 6 to 12 weeks. Anything below your waist or above your face may put you at risk of breaking your precautions or put you at risk of a fall. So if you're using a walker or using your reachers, things below your waist and above your face can be tricky, so get everything in that zone, waist to face. So now we're going to talk about each room in your house and what you can do to prepare that individual room to be safe and effective to use after surgery. So one of the rooms in your home that I refer to as a common danger zone is the bathroom. The bathroom is an area of high fall risk, especially because it involves water and slippery floors. But when it comes to bathing, we're going to recommend you getting something called a shower chair or a tub bench. When it comes to bathing, please also remember that you're not allowed to soak, so it's going to be showers only. So if you have a walk-in shower, a regular shower chair is what we're going to recommend. If you have a tub shower and you're worried about stepping up and over that ledge, there is a device called a tub transfer bench. We recommend shower chairs and tub benches because sitting down while bathing is safer than standing when it comes to fall prevention and when it comes to cleaning within those precautions. So again, when we mention sitting down, we don't mean sitting on the ground or soaking in a tub. We mean sitting on a type of designed shower chair. Other things that can make bathing much easier is a handheld shower head or grab bars. When it comes to grab bars, normally we do not encourage people to go out and get suction cup grab bars because they may pop loose without you knowing it. But clamp on grab bars, like a grab bar that may clamp onto the edge of the tub, is something that we do encourage as well. When it comes to toileting, sitting on a toilet and getting up from a toilet may be difficult after surgery. So please practice sitting and standing off your toilet before surgery, especially now that you know what our restrictions and precautions are going to be. If you find that your toilet is too low to stand up from safely without bending too much, please consider getting a riser or a frame. Also, those gadgets that I showed you, we refer to those as adaptive equipment. Things such as the reacher and the long-handled sponge and the toilet aid will come in handy in this area as well. So on this slide are some pictures of the items I just mentioned. On the top left is a picture of a tub transfer bench, and as you can see, it's basically a wide shower chair that hangs out over the edge of your tub. This allows you to sit down, swing your legs into the tub without having to step up and over that tall ledge. You can see the diagram on the very far right that shows this technique, where you sit down and spin, not twist, but spin yourself into the tub, and to get out of the tub, it's the same technique, just in reverse. In the middle picture is a clamp-on grab bar. Again, we do like to clamp on grab bars as an option for people with tubs where we don't like suction cup grab bars as they may let loose, but clamp on generally is considered much better. And in the bottom left is a picture of a standard shower chair, which works well for your typical walk-in showers where you don't have a tall ledge to have to step up and over. When it comes to these items, you can acquire them locally from a loaning closet, from a big box store, from a pharmacy, or even online. And here are some pictures of those toilet items I mentioned. The two pictures on the left are pictures of toilet frames. Oftentimes these are referred to as 3-in-1 bedside commodes because they come with a bucket, and you can see on the very far left picture, the bucket is installed to make this item similar to a porta potty. If you remove that bucket and set it over top of your toilet, it becomes a toilet frame. So again, these can be referred to as 3-in-1 bedside commodes or toilet frames. On the very far right is a picture of a toilet riser. Some risers have grab bars, like the picture that's shown, and some don't. These are basically extended toilet seats. And if you're going to get one of these items before surgery, I do encourage you to try it out to make sure it fits your bathroom and fits your toilet so you're not experimenting with these things after surgery. And the next area of the home that we're going to discuss is your bedroom and kitchen. And I like to talk about these two rooms together because I'm going to refer back to that catchphrase I had, waist to face. So when it comes to setting up your bedroom and kitchen, think about waist to face with all those items that you're going to be using over the next few weeks. With your bedroom, think about your dresser, your closet, all the clothing that you're going to be wearing over the next few weeks. You want to have easy access to those things. Clothing that we're going to recommend is baggy, loose, comfortable clothing. Avoid denim, things like jeans, things that are way too tight, because those are going to be hard to get on and off after surgery. And again, for the bedroom, remember that log roll technique that I mentioned. And also keep in mind the height of your bed. If your bed is too high or too low and requires you to break your precautions to back up and sit down, consider changing the elevation of that bed. With your kitchen, again, waist to face is my catchphrase. Think about your cabinets, think about where your microwave is, how your fridge is set up. All those items that you're going to be using over the next few weeks, have everything in that easy to reach zone. Preparing meals prior to surgery will make life much easier for whenever you get home, and think about that healthy diet high in protein to allow for good, healthy healing. And since I just discussed the bedroom, I just wanted to briefly review those items that I previously mentioned, the adaptive equipment, the reacher, and the socket, as these will be your bread and butter going home when it comes to lower body dressing, because anything below the waist may be difficult after surgery. So please remember that these are the techniques that we're going to want you to use to get your clothes on and off. And also another brief review on that log roll since we just discussed the bedroom. Again, the log roll is going to be very important to do after surgery to prevent breaking those precautions and to get in and out of bed without pain. So again, please practice this prior to surgery when it comes to setting up your bedroom. So let's talk about the other living spaces in your home. Remember that you're going to need ample space to move around your home with a walker, as most of our patients will be required to have a walker to go home. So please make sure you remove clutter to where you can move that walker around all the furniture in those living spaces. Also consider lighting in your home. Night lights or a dim bathroom light on will make things easy navigating, especially at night or in the dark, to help avoid falls. Other areas of the home to be very cautious of are the stairs. Please count the number of stairs that you have at home and pay attention to the handrail location, because physical therapy will be working on going up and down stairs after surgery to make sure that you can go home safe. And if you have a multi-level home, it may be worth considering setting your home up to where you can avoid stairs altogether by living on that main floor if your home setup allows it. And if you do have a multi-level home and you may or may not have a lot of help at home, please consider getting multiple walkers and keeping one on each level. That way you don't have to worry about getting that walker up and down the stairs, as the walker is normally not a device that you use to go up and down the stairs. When it comes to furniture in your home, please consider firm chairs with arms, as they are easier to get in and out of. Recliners are okay after surgery, but you want to make sure that you can get in and out without breaking those precautions and that you can reach those controls easily. Oftentimes I will recommend patients to play musical chairs prior to surgery. That way you can sit in and sit up from all your chairs and make sure that you can easily do that. That way you know after surgery that you won't get stuck in one of your chairs. With rugs, we do recommend all of our patients to remove throw rugs, especially those rugs that are in the bathroom, the small ones that can get underfoot. They also may be catching on your walker as well. Even large area rugs, we do encourage people to remove to not have any extra fall hazards at home. And again, make sure that your walkways are clear so that way you can get that walker through and not have any fall hazards around the house. So now we're going to be talking about transportation and driving. Remember, you will likely have driving restrictions based on your physician's order. So please check with your physician before surgery to know how long you're not going to be allowed to drive for after surgery. Typically, as long as patients are on those precautions, so for 6 to 12 weeks, we normally discourage driving, especially if you have a cervical collar, and especially if you're not able to twist to check blind spots. And even if you're good with mirrors and backup cameras, it's still a danger to be driving within those precautions. Whenever you're picking a vehicle to get picked up from after surgery, consider a mid-size vehicle. Very tall lifted pickup trucks and very low sports cars are tricky to get in and out of. So for after surgery, those mid-size vehicles will be much easier. The technique we want you to do is going to be backing up, sitting down in the seat, and spinning yourself into the car. And it's something that we encourage everyone to try before surgery to know what vehicle that you may have is easiest to prepare for discharge after surgery. So here's a quick diagram of that technique. Again, we want you to be in the passenger side of the vehicle to where you're going to be backing up, sitting down in the seat, and then spinning your body into the vehicle. That keeps you from having to have one leg up, one leg down, causing you to break your precautions or put you at risk of a fall. Other things that may make life a little bit easier getting in and out of the vehicle is having the seat all the way back and even reclining that seat a few degrees. You do not want to recline the seat all the way back, but sometimes 30 to 45 degrees of reclining gives you a little bit more space to spin into the vehicle to stay within those precautions. And lastly, let's briefly talk about pets. Pets can be an issue going home after surgery because sometimes they cause you to fall, they can cause you to get an infection, or even break your precautions. So we're going to ask you to come up with a good plan to care for your pet at home, including walking and feeding. After surgery, we are not going to want you to walk your dogs on leashes. And we also don't want you to be sleeping with your animal, whether it's a cat or a dog. Oftentimes, cats and dogs like to get underfoot or jump on you. So when you first arrive home from the hospital, we do encourage you to restrain your animal or have whoever drove you go inside the home, put the pet away, allowing you to safely enter your own home, get sitting down, and then allow your pet to come greet you. Also keep in mind when it comes to infection control that pets should not be laying on or near your incision site, and you should not be sharing blankets and sleeping spaces with those animals. So now that we've talked about therapy in the hospital and preparing your home for after your hospital stay, please remember therapy's 3 big rules for going home safely. The first one, no falls. The second one, no infections. And the third one, don't break those movement precautions. And please always remember, talk to your physical therapist or occupational therapist about any concerns that you have for returning home safely to your specific home environment, and we will gladly help you out to make sure that you can get home safely and successfully and have a great healing after surgery.
For questions and to receive credit for this educational program, please contact me, Donna Kager, at Alaska Regional Hospital. My office number is 907-264-1481, or you can email me at donna.kager@hcahealthcare.com. Thank you for viewing our presentation, and I wish you well on your upcoming surgery.